Thank you, ma'am. Now I would like to invite Dr. Rajesh Rajput for our next session. It is on diabetes reversal, myth or reality. I would also like to invite Dr. Rajeev Bansal, Dr. Chakraborty, Dr. Saurabh Srivastava, Dr. Meena Chhabra to chair the session.
So we have a very interesting session, and we had one glimpse of this session earlier in the morning workshop also, diabetes, whether it is reversible or not. And for this, we have an eminent speaker. You can see on the screen, the screen speaks itself, is the former senior professor and head Department of Endocrinology, PGIMS, Rohtak, more than 170 publications, national and international, various books, endocrine disorders in pregnancy, women health in diabetes, delivered numerous lectures at various conferences, won many awards.
Thank you very much.
And I think the list is endless. So I invite Dr. Rajesh Rajput, and I'm also thankful to him. Just by giving one call, he said, yes, I'll give the lecture. He has never said no. Thank you, sir.
Thank you very much. At the onset, I like to thank Rajeev, Paras, and all my friends of EDPA-CON, because I am born and brought up in East Delhi, so I have a soft corner always for EDPA-CON. That's why for years and years on, we are not here for 2-3 years. In COVID time, ये time count मत करना भी मैं 1-2 मिनट बात कर रहा हूँ. So I have not come because of the COVID, but thanks to post-COVID, we are having first post-COVID EDPA-CON, and the concept, when Rajeev actually has discussed this year, I thought let's discuss about concept of reversal of diabetes. And the reason very simple, this lecture I am going to deliver in National Endocrine Society Conference in December. Because now this concept is in fashion, lots of information is available on internet, and often patient ask about this concept. Large number of our doctors are also now diabetic. So if this diabetes can be reversed, whether this is a correct term or not, I will come to this issue, is an important thing. So I thought let's discuss this concept in MIDCON, when he has told me that he is discussing obesity, nutrition, wellness. So I thought it will be an appropriate topic to discuss all of you about the concept of reversal of diabetes, surrounding it, some facts, some fictions. You can start the slides now. So this is my topic, no conflicts of interest. Now let's first discuss about what is difference between remission and reversal. There are two important terms. If we see factually, reversal means restoration to good health, and remission means abatement or disappearance of signs and symptoms of a disease. Now for a chronic disease like type 2 diabetes, it is more appropriate to use the term remission rather than reversal. So first, this is an important concept. Reason is, nobody on this earth can develop diabetes until and unless he or she will have beta cell dysfunction. Now this beta cell dysfunction is a relative phenomena from mild to severe. And therefore, whatever maneuvers we are doing, we are actually doing a remission. We are not reversing the process. And again, this will be a common experience. As soon as patient stop all those procedures, patient again will have pre-diabetes or diabetes. Also, please remember, for type 1 diabetes, there is no concept like remission or reversal. So please do not try all these concepts in type 1 diabetes. Now what are definitions? There are 3 important definitions: partial remission, complete remission, and prolonged remission. Partial remission, when your blood sugars are in not diabetic range, means they are in pre-diabetes range, but you are not needing any drugs for 1 year. Complete remission, when glucose levels are completely within normal range with no medications for 1 year. And prolonged remission, when you can sustain this phenomena for next 5 years. So these are 3 important definitions when we are talking of concept of remission. So what are the questions The question is, are beta cell at diagnosis, which we have used to say are gone, are permanently gone, or they can be brought back to function? Next, if yes, how can we do this? Do we have any clinical evidence of remission? And lastly, can we use it as a therapeutic strategy? So these are 5 questions which we are going to answer through this lecture, and you will not ask me these questions again. Now moving forward, you must have listened in the morning sessions about concept of glucotoxicity, lipotoxicity. It is very, how they are causing diabetes, you know about it, but very recently Ross Taylor has given a concept of twin cycle hypothesis, which I am going to discuss, and then beta cell dedifferentiation, which slides I have removed because of the time allotted to me, but now there is a FOXO protein which has shown that when we try to reverse, there is a protein which helps us in differentiating beta cells into a normal process again. Now what is twin cycle? Now this is a very important concept to understand. We are now living in a positive calorie balance. All of us who are sitting here do not have hunger, but still when pakoras and all this stuff has come, we have eaten it. So this is a positive calorie. This is going inside us, is a positive calorie. When for a prolonged period of time, you live into a positive calorie balance, these excess of calories are deposited inside your liver as a fat. And liver in turn will have increased production of VLDL triglyceride. Remember, in all of us, adipose tissue is the organ where fat should remain, ideally. But when we have excess of calorie, which overwhelms the capacity of subcutaneous tissue, this excess of fat is spilled over and is deposited at ectopic place where ideally it should not be. Now what are those places? First is muscle. Muscle is the most important organ for glucose utilization. And when fat started getting into the muscle, in MR spectroscopy, if you will see the muscle, it will appear as white, and it is known as marbleization of the muscle. Similarly, your pancreas, normally it is less than 2 grams of fat, it is virtually free of fat. When you have excess of fat in the body, which is spilling over into the blood, it also gets deposited into your pancreatic beta cell. The result is pancreatic beta cell will not sense the ambient glucose level and start failing. So the glucotoxicity also comes into picture. So this is basically what Ross-Taylor hypothesis of twin cycle, that chronic calorie excess leads on to excess of deposition into liver and pancreas, which ultimately will cause beta cell dysfunction and will result in diabetes. What are the So do we have evidence for this twin cycle hypothesis? These are the evidences. Weight gain, which we are discussing since morning, is the strongest modifiable risk factor for type 2 diabetes. If you have closely seen your patient and monitored, rise in SGOT-PT and GGT happens even before patient develop type 2 diabetes. There is a change in insulin sensitivity as liver fat accumulates. Same is true for pancreatic fat, where first phase of the insulin secretion is lost. So the next part of twin cycle is, can reducing body weight will result in reversal or remission of diabetes? Now this is what is happening when a person goes into a negative calorie balance. What is happening? This fat is moved out of liver as well as pancreas, which will result in reversing this twin cycle, and it also will be causing improvement in beta cell function and remission of diabetes. So this is a concept. Now we all are scientists, so we need evidence. What are the evidences? Weight loss by any mean. Forget drugs, it might be behavior, bariatric surgery, combination of anything will actually result in remission of diabetes in some individual, not everyone, we will come to that. With reduction of body weight, there is normalization of rise in ALT and GGT level. There is improvement in insulin sensitivity. There is improvement in first phase of insulin secretion by pancreas. So there are all evidences associated with these phenomena. Now let's see some clinical trials. Let's look at evidence. These are three important landmark trials whenever we are going to discuss about remission of diabetes. Counterpoint study. What is counterpoint study? Counteracting pancreatic inhibition of insulin secretion by triglyceride. Counterbalance study, counteracting beta cell failure by long-term action to normalize calorie intake. And third, direct study, which is a diabetes remission clinical trial. Now, counterpoint study is a proof of concept study. Whether twin cycle hypothesis, which we have just discussed, can be really applicable to us. So, counterpoint is a proof of concept study. It involved only 11 patients, and they have these 11 patients had type 2 diabetes with average age of around 50 years, BMI of 33, 9 male and 2 females. And what they have done, patients were studied at day 0, 1, 4 and 8 weeks. So, only 8 weeks of study. These 11 patients were given 600 kilocalories per day, and these are all liquid diets. 600 kilocalories is not possible because one samosa contains 600 kilocalories. So, these are pre-made liquid diets given for 8 weeks, and you will be surprised to see the results. If you see the results of counterpoint study, within first week of giving 600 kilocalories of diet, this is fasting plasma glucose. See, fasting plasma glucose is somewhere here, 170. It has come to normal within first week. And if you see parallel in the liver, along with this, there is decrease in liver fat within first week, which keeps on decreasing till 8 weeks. And simultaneously, along with decrease in liver fat, there is improvement in insulin sensitivity. If we see at the level of pancreas, changes are slow to appear, and by 8 weeks, there is decrease in pancreatic fat, and parallel, there is improvement in first phase of insulin secretion. So, the counterpoint study proved that it is possible to normalize both beta cell function and insulin sensitivity by simply doing energy restriction. This is associated with reduction in both pancreatic and liver fat, and thus causing remission of diabetes. Now, the next important question then comes, we have tested the hypothesis in 11 patients. Can we apply on a larger number of patients with longer duration of diabetes? So, then counterbalance study was started, where these questions were answered. Can people with long duration of diabetes, we can do reversal of diabetes, and if reversal of type 2 diabetes is durable, if body weight remains stable. So, these are the two questions which are answered by counterbalance study. In counterbalance study, patients of short duration of diabetes and long duration, and they are divided into less than 4 year, 4 to 8 year, more than 12 year. It has been shown that short duration of diabetic patients have a better response as compared to people who are long duration of diabetes despite having similar degree of weight reduction. So, remember, weight reduction is not the only point. With same degree of weight reduction, short duration of diabetes have a better response. Then, if we see fasting plasma glucose and diabetes by duration, those who are having less than 4 years of diabetes, almost 100% of them are going to have remission of diabetes. In contrast, very few of them who are having more than 12 years of diabetes. 4 to 8 or 4 to 12 years is a gray zone. Then third study, which was done in UK, is a direct study, which is diabetes remission trial. We have learned, we have understood the concept from counterpoint study, counterbalance study. Then this is an open label study done at 49 primary care centers in Scotland and England. Because ultimately diabetes being a huge problem, our primary care physicians should be able to apply all these strategies. These are our inclusion criteria. I will rush with the slides. And the direct study has shown that with weight loss of 15 kgs or more, 24% of the participant in intervention group have remission of diabetes. And these are conclusion of the remission trial, where it has been shown 15 kgs loss of body weight is beneficial. So what are key learnings from these study? Key learnings from these study are 40 to 50% of the individual can have remission of diabetes, and the durability of remission has been demonstrated for at least 1 year. Younger age, less than 50 year, vis-a-vis more than 59 year, with shorter duration of diabetes have better outcomes. Individual who are needing lower number of medication at baseline, lower fasting plasma glucose and lower HbA1c responded better. And weight response neither depending on absolute weight loss. I have shown you that weight loss of even 15 kg does not mean everybody is going to respond. Why it is happening? There is no change in muscle insulin resistance on diet. There is reduction in hepatic glucose output, which is again comparable in both responder and non-responder. What has made the difference? It is beta cell function improvement, which actually had made the difference and had made people to go into remission. Now again, very recently, 2 years back, a publication has come that type 2 diabetes is not same. There are various phenotypic variant of type 2 diabetes. There are patients who are severe insulin deficient. There are patients who have combined insulin deficiency and insulin resistance. There are patients who have severe insulin resistant type of type 2 diabetes. There is mild obesity related diabetes, and also there is age related type 2 diabetes, because there is a natural age related beta cell apoptosis. And if we classify patients, our type 2 diabetic patient, into various subtypes, probably those who are having severe insulin deficient, they are not going to respond. Those who are having severe insulin resistance or the lower one, they are probably going to respond the best. So if we are going to apply the concept of remission in routine clinical practice, then we have to classify our type 2 diabetic patients into various phenotypes also. It is not one pill for every patient, that every patient is going to respond in a similar way. Before I end, there are very many future questions. I have given you a wonderful situation that we can do a reversal, but then more research is needed. Why I am saying so? How best is the initial advantage which is provided by low calorie diet can be maintained? Not only that, whether same low calorie diet is going to be beneficial for all type of individual? Answer is no. So we have to identify. Now we are moving into a precision based era. Like we are talking of precision based medicine, there has to be precision made diet, precision based exercise, precision based sleep, and for that already artificial intelligence is coming into picture. We are working for that algorithm also. We will discuss sometime else. So nowadays, with the help of artificial intelligence, we can give precision individual based answers to all this. Then genetic factors probably are most important. 72% of the people who have BMI of more than 40, that does not have diabetes. Why it is happening? So obesity is not the only culprit which we are discussing since morning. Genetic factors are equally important. Large number of people who develop type 2 diabetes, they have a BMI of less than 25 kg. And in trials it has been shown 16% of those who are aged more than 55 and 10% of those who are between 16 to 54, they are having normal BMI, still they develop type 2 diabetes. So it is not only obesity. All the studies on reversal are done with people who have a BMI of more than 27. We are discussing just Chinese study. Now what about those people? In our country, in our ancestry, we believe obesity, BMI of more than 23. What about those people who are developing diabetes at a BMI of 23 and 25? We do not have any. So these things needs to be researched. Weight loss, we are discussing since morning. Weight loss of more than 15 kg, mind you 15 kg weight loss is a huge amount, does not cause reversal of diabetes in at least 14% of the individual, even in direct trial. If you do bariatric surgery, because many of the time bariatric surgeons comes and they also give wonderful rosy picture all the time. But if you see a meta-analysis, a weight loss of more than 25 kg did not result in remission in at least 40% of the individuals. And even in those where it has happened, it has not sustained over a long period of time. Duration of diabetes seems to be a very important factor, which now has come even in algorithm for bariatric surgeons also, when they counsel the patient for bariatric surgery and give them how much is the chances for diabetes remission or reversal. Weight loss of more than 15 kgs or more than 20 kg is not at all is associated with more degree of remission or reversal. And lastly, South Asian phenotype, to which all of us belongs actually. All this data which I have discussed with you and the data which my colleagues or some other colleague or bariatric surgeons will come and discuss, they are actually done on Caucasian counterparts. We are basically different. So we do not have our dedicated outcome data as far as remission and reversal is concerned. So friends, over last 20 minutes, I have told you what actually remission and reversal means, how it can be achieved in real world, but there are many unanswered questions. So when we see a patient of type 2 diabetes and who are obese, we have to understand the excess of calories are causing problem, and cutting down on the excess of calories will take care of large number of abnormalities, including pancreatic beta cell function, decrease in hepatic insulin sensitivity, and not only that, there is a redifferentiation of beta cell. So the first phase of insulin secretion is lost. It seems to be an attractive but difficult task to achieve in real world. What I will conclude is reversal or remission, we should ideally say remission of diabetes is a reality, at least in early stages of diabetes. Partial remission is possible probably at all stages of diabetes. We can cut down the number of pills, we can cut down the amount of insulin patient is receiving. So partial remission is possible at all stages of diabetes. Thank you very much.
So thank you very much for an excellent eye-opening lecture which you have given. Sir, why then the time-restricted feeding or the intermittent fasting did not give any fruitful result? The time-restricted feeding. Time-restricted feeding or intermittent fasting, what you call. It didn't give much result regarding if you reduce the chronic calorie consumption, if you reduce.
With intermittent fasting, one has to understand very simple. I explain it in a layman terms. You have 1 crore rupees in your bank and you spent 10,000 rupees daily. It is like intermittent fasting.
Right.
But the amount of interest earned on 1 crore rupees is more than 10,000 rupees. So ultimately, your bank balance stays there. When we are doing intermittent fasting, no concept is applicable to everyone. When you are doing intermittent fasting, actually you have to go into a negative calorie balance. Only then this ectopically deposited fat will be moved out of those ectopic locations and will be burned by the body. So same degree of intermittent fasting might be good for me, but might not be good for you. And these 600 or 800 kilocalories are actually much higher than the degree of intermittent fasting which we are talking of. Now, like say another example, intermittent fasting. We have wonderful lunch, we have wonderful pakoras and coffee till 6 p.m. in the evening now. And after 6 p.m., now I will go on intermittent fasting. I will not eat anything till 8 a.m. in the morning. But already I have consumed 4,000 kilocalories in a day. So that amount of only 8 to 10 hours of fasting is not going to take care of this excess calorie which you have consumed in a short period of time. So it's a small calorie taken over a prolonged 6 to 8 weeks period of time, which is going to move out your ectopic fat and is going to give good results.
So there are certain medications, especially the oral hypoglycemic agents.
That is not my topic. Actually, I have avoided because of the time. But see, where is the role of medications in obesity?
Especially those give beta cell preservation.
There is no medication which gives beta cell differentiation.
Beta cell preservation, like DPP-4 inhibitors.
Who said? Pharmaceutical companies. We as a speaker, where is the evidence? See, if we talk of beta cell differentiation, first of all, there are only animal study. Taking pancreatic biopsy and studying really differentiation of beta cell is hardly possible in this world. In animal studies, the drugs which have caused actually beta cell differentiation are thiazolidinedione, but lot of side effects we are not using. It is not DPP4 inhibitor, it is GLP-1RA, increasing level to the pharmacological level. But then again there are some downsides. But then by doing reduction of body weight, probably we can achieve much more what can be done by the drugs. But where lies the role of the drugs? I have just delivered a lecture on obesity. When we talk of reduction of body weight, the next important barrier comes. It's like a toy. You stop your maneuvers, body weight will increase like this. Now when you have reduced your body weight, maintenance of body weight is equally important. So how to maintain it? Probably there lies some role of drugs and exercise. Even in pre-diabetes, if you reduce your body weight, you have reversal to normal. So Rajeev is looking at me again and again.
I think it's a very interesting topic, and we can go on because it's a new topic. So, thank you very much, sir. Thank you. Excellent. Thanks.
Thank you, sir.